Hello, everyone. Thank you so much for joining us for a discussion, recap of San Antonio. I'm Kristina Mirabeau Beale. I'm a board-certified radiation oncologist in Fort Myers, Florida. I work with GenisisUSA, a company that used to be known as 21st Century Oncology. And I'm also the director of our breast cancer program at our regional cancer center. And I'm joined today by some fabulous colleagues who I'll have introduce themselves. Sramila, do you want to start?
Hi, Kristina. Thank you for having me with all of you esteemed panelists here, along with our patient, Bethany. I am Sramila Aithal. I'm a breast medical oncologist. I work at Cancer Treatment Centers of America in Philadelphia. I primarily see breast cancer patients of all stages, and I'm pleased to be here with you all today.
Thanks so much. Anne?
I'm Anne O'Day from the University of Kansas Cancer Center. I'm a breast oncologist there, and I focus about 80% of my time on the treatment of breast cancer, and I spend about 20% on breast cancer prevention and genetics, and the medical director for breast cancer survivorship. So thank you for having me. I'm honored to be here.
Awesome. And Al?
I'm Alvaro Moreno. I'm a medical oncologist at Mayo Clinic in Jacksonville, Florida. And I also do only breast cancer.
Wonderful. And in some sense, most important, love to introduce Ms. Bethany Brosious, who is a patient of mine and also a wonderful patient advocate. Bethany, we'd love for you to introduce yourself and also share some of our story to, I guess, get our discussion started, please.
Sure, absolutely. And thank you guys for having me on this evening. Just to kind of give you a sense of who I am and my story in a nutshell. I live here in Southwest Florida, and I'm a patient of Dr. Mirabeau Beale. I'm a wife, a mom, an employee, and in July 2019, I was diagnosed with stage 2 triple negative breast cancer. After conferring with a team of doctors here in Southwest Florida, we sought a second opinion at the Moffitt Cancer Center in Tampa. After talking to the team at Moffitt, we were really on board with the aggressive approach they were going to take to deal with this cancer. And so we proceeded with neoadjuvant chemotherapy up there in Tampa, and also proceeded with surgery up there in Tampa. It was very successful. I had a complete response and came home after that to do my radiation treatments with Dr. Mirabeau Beale here in Fort Myers. With triple negative, we were interested in if there was anything additional we could be doing just to prevent or reduce the risk of recurrence in the future. So I started doing some research into clinical trials, and that took me to Dr. Carmen Calfa from the University of Miami. She was running a trial on a vaccine for triple negative cancer to help reduce risk of recurrence. During my conversations with her, it was seemingly, good. We were in agreement that I would be a good candidate for this. And as part of the evaluation, she decided to rerun the pathology and do some evaluation before signing me up for the trial. Upon that additional evaluation of my pathology, we found out that my cancer was in fact estrogen receptor positive and not triple negative. So that was kind of a surprise. And we changed direction at that point, and I started hormonal therapy. I started tamoxifen. So far, so good. The side effects are tolerable. Just moving on with life at this point and hoping for the best in the future.
Awesome. Well, thank you so much for so eloquently sharing your story, Bethany. I think, without speaking directly to kind of the decisions made in your care, you experience a lot of different transitions. And I think it's a good jumping off point to kind of, revisit some of the newer data that was discussed at San Antonio. But I guess, Al, I wonder if we should address at least some of the neoadjuvant approach maybe that began Bethany's journey and kind of segue into some of the other updates this year.
Yeah, so I think Bethany has the best outcome that she could expect it from the neoadjuvant chemotherapy. As we know, those patients who achieve complete pathologic response are the ones who do the best in the long term. She rightfully so looked for a clinical trial because unfortunately there are patients who still relapse after even achieving pathologic complete remission, and went to see Carmen in Miami to enroll in the Photoreceptor alpha vaccine trial. That's a trial that we share with them. This include to see if a vaccine targeted to the Photoreceptor alpha in patients with triple-negative breast cancer can lower the risk of recurrence at 3 years. And pretty much the eligibility these days for that trial allows patients who has a tumor of 1 centimeter or larger to enroll, or any patient who did not achieve complete pathologic response during neoadjuvant chemotherapy. And now as part of the trial, we do request re-review of the pathology as well as staging just to make sure there's no evidence of any disease elsewhere. And that's how Bethany was able to find that tumor was actually ER positive. But if she were to go on the trial, the vaccine is fairly well tolerated. It's given once a month for 6 months and then once every 6 months for 3 years, as the risk of relapse in triple-negative breast cancer is to be largest in the first 3 years. On the other hand, I'm very glad that Bethany was found to be ER positive because that provides her with excellent adjuvant treatment with the endocrine therapy.
Bethany,
So-
I want to ask you, what were the chemotherapy medications that you received neoadjuvantly? Do you remember them?
I do. I received Abraxane, and I don't remember the name of the drugs, but it was the AC treatment.
Okay. Well, I think, Kristina, as you were asking about the neoadjuvant options of treatment, I think it was presented at San Antonio last year, this keynote study for early stage triple-negative breast cancers that are node positive or T2 lesions, to receiving chemotherapy alongside with pembrolizumab immunotherapy, followed by regular adriamycin and Cytoxan-based regimen. And I think, if I recall, that study had shown a significant improvement of more than 13% in the pathological complete response benefit as compared to just chemotherapy alone. And there was one more study subsequently presented as well. That was in Passion 31 trial, where atezolizumab was combined with chemotherapy in the neoadjuvant setting, which also showed a 16% absolute improvement, a difference in the improvement in PAT-CR favoring immunotherapy alone. So I think these are emerging data, combining immunotherapy with chemotherapy for obtaining better pathological response in the neoadjuvant setting.
Yes, it was wonderful, especially that Bethany was able to have a complete pathologic response. I think we know that that portends a better prognosis overall. And certainly looking at some of the newer data from this year, the responder trial, and kind of looking at potential de-escalation of chemotherapy in patients based on their recurrence score. So I don't know, Anne, what are your thoughts on these exciting data?
Yes, thank you so much. And thank you again, Bethany, for sharing your story. We can learn so much from what you shared with us. And I think importantly, one of the take homes for all of us is we are here tonight as a multidisciplinary group. We have radiation oncology and medical oncology and patient advocates. And I think, every patient, especially when we're making a decision about neoadjuvant or adjuvant chemotherapy, deserves a multidisciplinary discussion and really helping understand. I always explain to my patients that, sometimes everyone on the team, everything that I do as a medical oncologist can end up affecting what they do, and what they do can end up affecting what we do as well. So I think that multidisciplinary discussion, pathology review, all of those things are so very important. But to your point, the responder trial, which was so greatly presented by Kevin Kalinsky, it basically was helping us understand for patients that have a recurrence score between less than 25 or less. So those patients that kind of from Taylor X emerged as that moderate risk subgroup, are there patients that are node positive in that subgroup that we can really that really don't derive much benefit from chemotherapy. I think, we've always wondered what to do with those patients. Many of us always felt that, particularly for those that were very endocrine sensitive, that maybe the benefit of chemotherapy was very small, if any at all. And so really this was the first big trial that included node positive patients that allowed us to really look at that, particularly using the Oncotype or 21 gene recurrence assay. Indeed, what they saw was that for the postmenopausal women that had a score under 25, there really was no significant benefit of chemotherapy, those that had 1 to 3 lymph nodes. So again, the trial was limited to people that had 1, 2, or 3 lymph nodes, not anyone that had 4 or more lymph nodes. So I think I'd be curious to get my colleagues' opinion about sort of this cutoff that we use. Is there really something different between a patient that has, low volume nodal disease, but maybe has 4 lymph nodes instead of 3? Would anybody feel comfortable omitting chemotherapy for the patients that had more lymph nodes? And how do you feel about this data for people that have 1, 2, or 3 lymph nodes? Is this going to be practice changing for you tomorrow morning in your clinic? Al, what are your thoughts about that?
Well, I can tell you, when this trial was first being discussed as design many years ago, there were oncologists who were advocating that biology trumps everything in regards to TNM, and why don't we just let any positive lymph node to be able to enroll as long as the current score was 0 to 25. And there was a lot of hesitation in some of the group because we've been doing chemotherapy for this patient for so long. And that kind of how it ended up being just the 1 to 3 positive lymph node. And unfortunately, with the 4 and more positive lymph node, we don't have the data. But like you said, makes you wonder at 4 positive lymph node with grade 1 the lobular disease with a strongly ERPR positive, how much benefit it will get from the adjuvant chemotherapy. But liking that data, I'm going to have to say we should just restrict that information right now to the 1 to 3 positive lymph nodes. And one of the big home to me was like, well, if you're premenopausal with 1 to 3, we shouldn't be ordering Oncotype anymore, because at this point everybody should get the adjuvant chemotherapy. On the other hand, on Tuesday, I saw a patient exactly that was 55 years old. First question I got when I got into the room, are you pre or postmenopausal? Her recurrence score was 24. She had only 1 positive lymph node. And so I was able just to offer endocrine therapy. So that was great.
I think you both bring up very good points that a lot of these studies have certain cut points in mind, but patients are on a continuum. And is there really a difference between 3 versus 4 lymph nodes? And we all know that biology is really driving this, but it can be hard to sometimes divorce ourselves of kind of how we think of the clinical risk factors, especially looking at young patients. I'm curious, guys, going into next week, for your patients who are, let's say, premenopausal with, let's say, 2 small micromets. I mean, are you now going to start sending, using this data, as soon as next week in making your clinical decisions?
So I don't know about others, but it's been my practice to, in premenopausal node positive patients, to really use the MammaPrint assay, because I felt like the data from the MIND Act really was there to support that. Those patients were included all along. So I would really like to know my colleagues' opinions about, will this change the assay that you order? Do you order both? How do you decide which patients to order which assay?
Yeah, well, I would say that RX Ponder, the patients here were followed for 5 years, as compared to MIND Act and TaylorX, it was 9 years that they had follow-up for. And when it comes to the number of lymph nodes, I want to bring it to the attention that in RX Ponder, it was only 9% of patients that had 3 lymph nodes positive. So, I would be careful in omitting chemotherapy in patients who had 3 lymph nodes and other prognostic features that might be of high risk in postmenopausal women. Well, of course, we know the results, yes, in postmenopausal women. People who have a score more than 25 definitely would benefit from chemotherapy with endocrine therapy, and people who have a recurrence score less than 25 probably 1 to 2 lymph nodes, I would omit chemotherapy. 3+ or more lymph nodes, I would be cautious looking into some other features into their tumor before making that decision. And of course, younger patients will definitely offer chemotherapy. I think, in my opinion, the interpretation of this RX Ponder, it really shows the importance of the assays or the biomarker that really we need to test in more prospective trials, I would say. I think it's really important. Another question to ask is, did tumor size make any difference at all in these scores? And they were less than 25. Of course, is a genomic variant that's responding to chemotherapy? Is ovarian suppression adding anything at all? We really need to answer a few more questions, in my opinion.
And I was going to just add that on what you just said on 3 positive lymph nodes in the ADAPT trial, there was also presented at San Antonio. This was a German trial. It was a little complicated design, but you're just trying to bring the point that when they look at patients in group 2 that had 1 to 3 positive lymph nodes, a recurrence score between 12 and 25, and a Ki-67 that didn't decline more than 10% after 3 weeks of endocrine therapy, there was a difference on the 5-year outcome of distant disease-free survival between patients with 0 to 2 positive lymph nodes versus 3 positive lymph nodes. So at the end of the day, you got to combine a little bit of the genomic with the clinical parameters in order to make a decision.
Totally agree with you. And I appreciated the design of ADAPT because, looking at really trying to understand if patients have endocrine responsive tumors. So not considering so much tumor size or any of those other things, but looking at true endocrine responsiveness. And I wonder if that's going to be sort of the way forward for us, where we are combining a real-time assay of genomics, but also with a true measure of endocrine responsiveness. One of the things that I was bothered by from ADAPT, I believe it ended up showing that the people that were kind of endocrine resistant, even people that had very low recurrence scores, like single-digit recurrence scores, still seem to have a benefit from chemotherapy. And that's not really a group of patients that we traditionally would offer that. So I think it kind of just highlights this idea that you seem to have some tumor biologies that will really benefit from chemotherapy, and some that are really very endocrine sensitive and maybe can avoid that. What are your thoughts?
I think I completely agree with you, and that is a concern. But I also think in ADAPT, I think we could consider them as independent predictors for PathCR, whether it's the recurrence score or the tumor features such as tumor size. I think they may be independent predictors, or even Ki-67 for that matter. So I think that's interesting to see how that pans out with the recurrence score, the endocrine therapy response, and the PathCR rate that they have. And who would be candidates for neoadjuvant chemotherapy or not. I think that would be interesting to see.
And I think as much as we try to eliminate, or not eliminate, but we understand that the size probably doesn't matter as much, I often worry when we have patients that have these large tumors, sort of like in Bethany's situation, maybe there was some tumor heterogeneity there, maybe it wasn't all, her tumor wasn't all one thing. There may have been different cell populations. And when we have patients that have very large tumors and we order, for example, a genomic assay on the biopsy specimen, and then we're making our decisions, based on that, I wonder about that and that idea of tumor heterogeneity when we're placing so much now on these genomic assays. If the thought is just, my concern is always for these very large tumors, is to make it more likely that there's tumor heterogeneity.
So if we were not to offer chemotherapy in select patients based on the recurrence score, let me ask Bethany, how would that make you feel if you were offered chemotherapy versus not having chemotherapy? Do you have any thoughts?
I do. And I guess taking the absolute most aggressive approach was very important to me and my family when we made our decisions. We wanted the very best chance at long-term survival of this. So when offered chemo, I mean, there was no hesitation. And it probably would give me pause if I knew chemo was sort of the standard of care and then all of a sudden the course changed.
I think, Bethany, you were mentioning that initially the thought was the lymph nodes were negative, but subsequent review or so, they found evidence that maybe 2 lymph nodes were positive.
That's correct. Yeah, after surgery, they found treatment changes in 2 of the lymph nodes. So
if in the spring, additional adjuvant therapy were to be approved, such as abemaciclib, based on the Monarchy trial, in which patients with positive lymph nodes were randomized to either just the hormonal therapy alone, which is what you're taking, or the hormonal therapy plus 2 years of this drug called abemaciclib, would you be interested on considering such therapy?
I personally would be. Like I said, we're big believers in science in this house, and we're looking for the absolute best chance possible.
Thank you so much for sharing that, because I think it's sometimes hard for us. One of the things we struggle with, the Monarchy data that was presented that looked at, adjuvant CDK4/6, in this case, it was abemaciclib, which is taken continuously as opposed to intermittent dosing like some of the other CDK4/6 inhibitors. It did actually show an improvement in invasive disease-free survival, which is so very important for someone like you who's in the prime of their life and has so many years in front of them. And I often wonder, because in this particular study, the benefit, I believe, was about 3.5%, something like that, in terms of invasive disease-free survival. And of course, we need much longer follow-up. We don't know if that will continue with more time. We don't know if these curves will just come back together. I'm very interested to see what happens when all of the patients stop taking all of these drugs, right? In your case, it would be tamoxifen. In the case of this trial, it would be, an aromatase inhibitor and then the abemaciclib. But do the curves just sort of come back together? But I'm very interested to know, is there some threshold for you as a patient, that number that would make you say, I want to take this extra therapy. I want to take this extra pill for 2 years. For some patients, it might be 1%. For some patients, it might be 20%. And I'm just curious, as a patient, when we talk about more toxicity, maybe more fatigue, maybe more upset, GI upset, things like that, is there a number that you feel like, I know I'm putting you on the spot, but I'm just curious if there's a way for you to kind of measure that? Because I'm always blown away when I have these conversations with patients. I'm always blown away that I can present the exact same data to one patient and she will say, absolutely, I want to do that. And I can present the exact same data in the exact same way to another patient and she say, well, why would I do that for such a small benefit? So I'm just curious what you think in terms of, is there a number in terms of a percentage of improvement that would make you want to take an extra pill for 2 years?
Sure. And just to, try to quantify a number, maybe in the 5% range. I think that's a indicator of significance when you're looking at, added value or value taken away. At the same rate too, would that, once you take that additional pill, how's your quality of life affected? And would the 5% be worth it? So I think it would be something that you kind of had to measure as you go along. But I mean, for me, I think 5% would be a significant benefit.
I think it's a really good point. An absolute number in terms of, benefit, in terms of quality of life versus length of life. I think also convenience factors, like how a medicine's dosed and the different side effect profiles. I mean, I'm curious if some of my colleagues can speak to, I guess, the differences between some of these CDK4/6 inhibitors and how the decision is made for a given patient.
So I was going to ask Bethany first, if I were to say this drug will lower 29% your risk of recurrence, would you consider that, right?
I would. I mean, 29% sounds pretty significant.
I'm just tricking you because that's a relative risk reduction. So in that trial, it was a 29% reduction compared with the endocrine therapy alone, but the absolute difference was only 3%. So it's what Anne was saying, depending on how we present the data, patients may decide one way or the other. But in general, with the three CDK4/6 inhibitors, palbociclib, ribociclib mostly is blood cytopenias, low blood counts, especially white blood cell count, neutrophils, while abemaciclib is mostly diarrhea. And in this trial, fatigue, neutropenia, diarrhea were the most common side effects. Although I think with those reductions, most patients can tolerate. And I think there was almost 70% of patients were, although they had some dose holding or reduction, 3/4 of patients were able to finish their therapy, if I recall correctly. So there are some side effects. They can be managed by dose reduction or holding. So I wonder about what Anne Sramila is using more in their practice in metastatic disease right now, which of the three agents. And before I finish, by the way, the Natalie trial, which is have kind of similar design as Palace in Monarchy, is currently ongoing. And I think in Fort Myers, they are running, if you were to be interested, I don't know the window, if you're maybe outside that window, but that's kind of similar design of endocrine therapy alone versus endocrine therapy with ribociclib, which is one of the other CDK4/6 inhibitors.
Okay, thank you.
Yeah, we are participating in the Natalie trial as well. But, coming to the point in the adjuvant setting, yes, we do know that there are a few relapses in this setting in estrogen receptor positive, HER2 negative breast cancer. And the biggest question is adding a second drug like a CDK4/6 inhibitor, how much is the benefit? Yes, we did see the benefit in Monarch E trial where abemaciclib was a CDK4/6 inhibitor combined with endocrine therapy. And the follow-up here was really for a very short period of time. Likewise, we also saw in Palace trial where palbociclib was the CDK4/6 inhibitor combined with endocrine therapy for stage 2 and stage 3 hormone receptor positive breast cancer patients, and did not see any difference in improvement in invasive disease-free survival. And no doubt they updated at the San Antonio last week, the Monarch trial about their invasive disease-free survival, which continued to show an improvement. And then we wonder, why are these differences when we see such similar results? In fact, I think the curves sort of overlap with all three trials in the metastatic setting, but why in the adjuvant setting, these are not giving similar results? I think there are a lot of differences in the way that the study is being conducted, and that's entirely the reason, I would say, and not entirely one of the reasons, to bring in some of the points in Palace trial. There were only a small percentage of patients that had high-risk features like a lot of lymph node involvement as compared to almost 60% in Monarch E trial. And then also in Monarch E trial, if they did not have high number of lymph nodes, they had many other high-risk features, whether it was Ki67 or tumor size that was much larger. So the selection of cases in Monarch E was quite different. And then in Palace trial, patients discontinued the drug quite a bit. It was 2.5 times higher fold in the Palace trial as compared to Monarch E trial. So then that brings us to answer the next question: is continuous dosing any different from intermittent dosing? With abemaciclib, we are giving it every day without a break, whereas with palbociclib, we are using 1 week off after 3 weeks on. So is there any difference? And then also, is there any difference in the CDK activity, CDK4 versus CDK6? So I think so many questions that we need to ask. And of course, the biology of early stage breast cancer versus metastatic breast cancer, are they different? Is that why in metastatic breast cancer, all these three drugs are working, whereas we're not seeing much of a difference in select drugs in the early stage setting? Those are some of the questions I think we need to answer. Even Penelope B that was, I think, using palbociclib here after neoadjuvant treatment that they got, and they went on to have surgery and then radiation. They were randomized to receiving palbociclib with an AI versus placebo. And they didn't see any difference in both of these arms when they followed up at 3 years, an improvement in their invasive disease-free survival. So ultimately, it brings down to the point, what are the endpoints? Are the endpoints same across all different subtypes? You know, patient selection, that's really crucial too. PALLAS failed because of that, I would say.
Yeah, and I agree with you about, you know, if you look at Penelope B, you know, initially it looked like there was going to be a benefit. There was definitely a separation of the curves, and then with longer follow-up, they sort of came together. And how do we interpret that data? And is that what we will see with Monarch E? We have no idea. I hope for our patients' sake, that's not what we see. I hope that we continue to move the needle for patients in the adjuvant setting. I appreciate your point about the continuous dosing versus intermittent, though. I wonder if that matters more potentially in the early stage setting. If you look at Cynthia Ma's work from WashU, looking at neoadjuvant endocrine therapy, and a lot of the trials where they will show that stopping the neoadjuvant endocrine therapy with CDK4/6 inhibitor for only a week or two prior to surgery, you see this dramatic, you know, increase in Ki-67 just being off your CDK4/6 inhibitor for a week or two, sort of suggesting that maybe, you know, especially when you're talking about 2 years of adjuvant therapy, maybe there is something to the continuous dosing. I don't know. What are your thoughts about that, Al?
It may be, or my personal experience is I can keep patients on abemaciclib longer by adjusting the doses. What we're trying to say is easier to manage the diarrhea than the blood cytopenias for many patients. Require the on and off rechecking of counts and so forth.
I need to take a lesson from you then, because I found just the opposite to be true. We'll have to talk offline afterwards so you can help me with that.
But makes you, I mean, if Natalie does show to be a positive trial and the results of Monarchy hold for a long time, and considering the survival benefit of ribociclib and abemaciclib in the metastatic setting, the overall survival on those trials, makes you start wondering if there's a difference on the compounds, although the PFS in the metastatic setting is about the same with all three compounds.
Mm-hmm. By the way, they did amend the protocol in Natalie trial after having observed the results of PALLAS and Penelope. They stopped accruing patients with stage 2 disease. They are only taking stage 3 with high-risk features. So pretty smart move. And Natalie is for 3 years as compared to Monarch E. CDK is for 2 years with an AI. Yeah, ultimately, I think it's the biology of breast cancer that's important, risk stratification that's important, and it's all about personalizing treatment, choosing appropriate patient for a given trial. And I think earlier you asked me about my choice of CDK4/6 inhibitor. In the metastatic setting, I certainly choose a CDK4/6 inhibitor based on individual patient and their risk factors and the side effect profile, because clearly the results are identical. So I think looking into the side effect profile and the given patient's comorbid problems, that's how I choose a CDK4/6 inhibitor.
I think I've heard the discussion. I'll just throw a question out there for you guys. I think one of the comparisons I've heard is, Coke versus Pepsi and making the decision. I'm curious for you guys as providers, and also Bethany, as a patient, hearing the differences in continuous versus intermittent dosing, the different side effects. I mean, what would be important for you to hear your doctors, in kind of help and guide you make the decision, do you think, if you were to decide to, consider taking one of these medications?
I mean, it would be very important to me, as far as side effects, to be able to carry on with normal daily activities. As a younger woman, I have small children, I have a job, I have a family. If one of these medications prohibited me from being able to carry out normal daily functions, that would be a deterrent.
Yeah, that's really important. And that's what we want to keep in mind when we we recommend all these medications to our patients, how are we affecting their quality of life? You know, you want to lead your life as normal as possible.
Along those lines, I've wondered, and I'd be curious what Bethany's thoughts are about this, is that, you know, looking at the CDK4/6 inhibitors in the adjuvant setting, which will be, of course, more appealing if Natalie is positive, and then we have monarchy if that data with longer follow-up continues to stay positive. I've always wondered if there's a subgroup of patients, very, very endocrine sensitive, that we could maybe not have to undergo 5 to 10 years of endocrine therapy, but perhaps they could have 3 years of an AI with a CDK4/6. So in other words, to elect for a slightly more intensive treatment over a shorter period of time, understanding that they sort of get that treatment over with and then sort of go back to their normal life. And that's something that I take care of a lot of really young patients. I have a lot of patients in their 20s and 30s. Many of them have not had the opportunity to have children yet, and they're wanting to sort of get done with their endocrine therapy so that they can go on and try to have a baby. And so many of them, I think, would elect for a more intensive, shorter course of therapy to sort of be done with that. And I don't know what your thoughts are about that, Bethany. Is that something you would ever consider? If someone gave you a choice of sort of a less intense therapy that was 5 to 10 years versus a more intense therapy that was 2 or 3 years, would you have a strong feeling either way?
I probably would. If I were a younger woman that was still looking to have children, it would probably be very important to me to finish whatever course of endocrine therapy was required, so that I could move on with my life and hopefully start a family. You know, that said, I would obviously want to speak to my doctor about, is the outcome with these medications comparable? Are you seeing the same effect on a shorter 3-year course that you would on 5 to 10 years of a different type of medication? So that, you know, those would be a couple of items I would want to consider.
I think we need to way longer follow-up in order to make that kind of decision. As you know, up to 50% of recurrence could be beyond 5 years. And one of the concerns with these trials is they're selecting such a high-risk population with large tumors or positive lymph nodes, and then you see these curves dropping. Makes you wonder whether we're not just treating micrometastatic disease for the first 2 years, and that's why they have such a great control initially, and then it's just dropping after we stop the therapy and the micrometastatic disease reemerges. So that's recurrence.
Absolutely. That's such a great point. And I think also, you know, going back to responder, you know, one of the things that I struggle with in that trial is that because of the era that trial was designed in, you know, that was really, the trial was being accrued and being conducted and designed really before we had the data from the soft trial with ovarian suppression. So it was really a very small number of patients in that trial. I think it was only something like 15 or 16% of the patients that were premenopausal got ovarian suppression in that trial. And so I think that that's something that is going to complicate things, and understanding that, you know, looking at things like ovarian suppression, it often takes that very long follow-up before we start to see the benefit emerge. And what are your thoughts about that, and this idea that maybe the benefit of chemotherapy in our younger premenopausal patients is actually that it renders them postmenopausal, or that it accomplishes ovarian suppression? What are everyone's thoughts about that?
Yeah, I certainly agree with you. That's a question that really needs to be answered. Yes, in the study, there were quite a few patients that were younger than 50 years, but yes, it was only 16% of patients that got ovarian suppression. So could ovarian suppression explain the chemotherapy benefit in younger women, especially those that have much lower genomic expression scoring? Could that be that? Could that be? I mean, that's why I think the hypotheses didn't really work, and they had to look into all the variables here, the chemotherapy, the recurrence score. So they had to look into that. So I think that's a great question that needs to be answered. I don't think we have, we really have a clear-cut answer as to is it a true chemotherapy benefit versus ovarian suppression benefit? Yeah.
Al, how do you help your patients understand that? I often have patients, that I may recommend, a young, say a, 37, 38-year-old, strongly premenopausal patient that, maybe has a score of 23, 24, something like that in terms of the oncotype. And I routinely will recommend chemotherapy for those patients. But this, hypothesis that maybe we could accomplish the same thing with ovarian suppression and an aromatase inhibitor. Are you feeling comfortable with that strategy? Is that something you're doing in your clinic, or are you offering all of those women chemotherapy?
Yes and no is the answer. So it depends on each patient and the clinical characteristics of their tumor. I don't think I'll be very comfortable in an early 30-something-year-old avoiding the chemotherapy. On the other hand, a 48-year-old woman with tumors that are, T1, maybe a T2, negative, and has a recurrent, and it's still premenopausal, but menopause is around the corner. So it's, I think, a different discussion. So I look at each individual case separately. I have the table from the trial with every group age and every recurrence score, and I just go over that with the patient and try to help them to make the best informed decision. But a young patient like that with a recurrence score between 16 and 25, I would, especially 21 to 25, I would recommend the adjuvant chemotherapy.
That's what I've been doing in my practice as well, but it's becoming a difficult decision for patients because, those hypotheses are certainly out there, and they're reading those and, looking at these very, very wise and esteemed colleagues of ours that are, discussing the possibility that maybe it's just the endocrine therapy and ovarian suppression that's really accomplishing the benefit here.
Let me ask you then, what you do with somebody who's 50 to 53, but is still premenopausal?
So I think that is such a great question, and I appreciate it. I believe in Responder that they didn't so much use 50 as a cutoff, they actually used premenopausal and postmenopausal. And I so appreciate that because I always struggle with these women who are 51, 52, but still tell you they're having a cycle every month, like clockwork. And I wonder if I tend to want to include those people in the premenopausal analysis as opposed to the 50 as the cutoff. And am I correct in that in Responder, they just used premenopausal and postmenopausal? They didn't use age really as the breaking point. Is that correct?
Yes, that is right. I think they looked at the prognostic significance of 3 variables. One was chemotherapy, the other was recurrence score, and the third was menopausal status, whether they were pre or post-menopausal. So they were independently prognostic for invasive disease-free survival. So yeah, you're right. I think it's hard to keep a cutoff age because menopausal status varies for different women. Some are in menopause in their early 40s, whereas some are in menopause in their mid 50s. So I think that 50-year cutoff is arbitrary. So rather use menopause versus premenopause. That would be a better term.
So talking about the escalation, I would like to know what Kristina think about avoiding radiation therapy in certain group of patients.
Yes.
Happy to speak to it. It's funny. I was listening to you guys back and forth and thinking, oh, it's just so much easier with the radiation field. They don't change with age. But I mean, yes, obviously, Prime 2 was updated and, essentially looked at women over 65 with node negative, ER positive early breast cancer, and showed that we can safely omit radiation in those patients without compromising overall survival. It comes up frequently in the clinic that, oh, so does that mean radiation doesn't add anything? And it's not that radiation doesn't add anything, but I think the local recurrences were different. I think on the order of 10% versus 1% in patients who actually had the radiation. But I think it's what we're coming up again. It's coming up again and again, whether in our Responder or now with Prime 2, trying to basically de-intensify treatments to save our patients the potential long-term side effects and quality of life implications, especially if it's only of marginal kind of benefit to their overall oncologic outcome. How are these data being applied kind of in your multidisciplinary clinics and settings?
We discuss in patients over 65 about the CLGB data. The issue to me is, you know, a 2% versus a 9%, depending on how you see also this, the data we were talking earlier today, is it 3 times the recurrence, the local recurrence rate, and you have to go all over again, or you have a 90% chance that there will be no recurrence and you don't need to have the radiation therapy. But one of the issues I think is coming up is we're de-escalating chemotherapy, then we de-escalate the radiation therapy, but the caveat is as long as they take their endocrine therapy. So you put all the way to the endocrine therapy, now they come to the clinic and they try all the 3 AIs and they hate it and they want to stop. And they said, but you told me I was a low risk patient, why do I need to take it? I'm not taking it anymore because I didn't need chemo, I didn't need radiation therapy. So, and this endocrine therapy is making me miserable, so I don't have to take anything. And sometimes I wonder, you know, when we start escalating so much and we put so much weight on the endocrine therapy, and we know many patients end up stopping their endocrine therapy somewhere along the line, are we going to get the same results?
And the same can be said of a responder, right, with the chemotherapy, because if we start saying, well, we could achieve the same thing for people who have limited nodal disease, who are premenopausal, and we just offer them ovarian suppression and you know, in the absence of chemotherapy. But again, it's all contingent on the fact that those patients are able to tolerate ovarian suppression with their endocrine therapy, which in my experience with very young patients in their 20s and 30s, ovarian suppression with an aromatase inhibitor is harder probably than chemotherapy. It's certainly much longer, and it's so often harder for them to endure. I think it of course depends on the woman, and it depends on their own unique situation and all of those things. But I mean, that's something I so appreciate what you're saying, because you know, we're the ones who are hearing from the patients at 3, 4, 5 years when they're saying, you know, they're having such a hard time, they can't sleep, they have brain fogginess, painful intercourse. I mean, all of these issues that they're struggling with as young women. I think it's just so important that we make sure when we're discussing with our patients these caveats that we talk about, this is what this treatment looks like, and this is what this looks like, and make sure, and just making those discussions really complicated, I think.
Yeah, I really wish all of our patients are going to be like Bethany, who commented earlier that she's tolerating tamoxifen well. That's not really the case in my practice. I do hear a lot of complaints from my patients. But I did wanted to ask Kristina a question. Yes, we do have the updated results from PRIME 2 trial about emitting radiation in patients more than 65 years of age with low risk features. But don't we also know that as time goes by, the risk increases for local recurrence? And someone who's 65 years old will certainly have a longer lifespan these days. And with each year, the risk increases. How do you feel about offering it to a 65-year-old as compared to 75, 85-year-old? I mean, I feel comfortable omitting in a 75, 85-year-old, but in a 65-year-old, I still have my reservations.
I completely agree. And I think it very much has to be a very an individualized discussion because it also depends on patient comorbidities and performance status. I think if you have COPD and diabetes and hypertension, you know, possibly this very small ER positive early breast cancer, you know, isn't necessarily the limitation to your overall mortality. But that said, with patients living longer with better treatments, you know, the risk doesn't disappear with time as the curves extend. And it also is dependent on adherence to the anti-endocrine therapy. So at least in our practice, I think it very much comes down to keeping kind of an open dialogue. So, you know, if patients attempt anti-estrogen therapy and they're not tolerating it, then we end up seeing them back, not at the 2-3 year mark after surgery, but, you know, in shorter interval. And obviously, you know, I think this is somewhat of a moving target. it's interesting since even the post-mastectomy radiation discussion, in a patient like Bethany who had a complete pathologic response in terms of how we're designing our radiation fields, there's some discussion as well. And we're waiting more data to see if we can de-intensify our radiation fields. But I kind of share your concern that as we de-intensify treatment, we want to make sure that we're not compromising outcomes, I think, going forward.
Especially today that, it's those patients who have low risk features, the one you're going to provide usually shorter radiation therapy. And often I tell the patient, now with prime 2, you got a 0.9% local regional recurrence versus 9.8%. The question is, do you want to go through all this all over again 10 years down the road or 7 years down the road because of a local recurrence? My other issue with the older data, the CLGP data, is I might be the oldest one here in the group, but I remember back in the 90s that you were in the late 70s and you were considered old. That's not the case today. And like Sramila was saying, you're 65, you're 70, you probably have another 20 years ahead of you. And local recurrence does impact having to go through all the surgery. Maybe the next tumor requires chemotherapy. You're not that young anymore. So, and again, these patients are lower risk features. So you probably be doing 3 weeks of therapy, and we're doing a study now with 5 days. So it's not the inconvenience or the toxicity it used to be. The machines are so much better that you don't see the cardiovascular damage that you could have seen before. So, and also I think in prime 2, patients with low ER had a much higher risk of recurrence. So you have to be careful that it's just because it's ER positive, that doesn't mean that it's a good hormone receptor positive cancer. So.
You mentioned about the ER, bringing up the biology for local therapy. And I'm curious what Kristina thinks about some of the trials that are, looking at, we've talked a lot about the genomic assays as predictors for our systemic therapy, but what do you think about some of the trials that are looking at the genomic assays to help determine the local regional treatment?
So things like Taylor RT that's still accruing, I think absolutely. We have to believe the science, right? If we're saying biology is driving a lot of this, I think just as we have to feel comfortable for a woman who has 1 to 3 lymph nodes positive with a low enough recurrence score, that they do well with endocrine therapy, that probably similarly, that will hold also for radiation. If you even look at some of the other data, like even something like Amoros, patients aren't necessarily failing in the axilla in the era of sophisticated systemic therapies. So I do think that potentially we'll be able to de-intensify our fields, and that'll be probably better for patients who can then be spared kind of the comprehensive, breast, chest wall, and regional nodal fields that we've done for so long. Now, as to whether greater than 4 nodes will then be down the pike, that's a whole other issue.
We are talking here in estrogen receptor positive setting, early stage, that more is not always better. But on the other hand, in HER2 positive early stage setting, we are talking about more treatment, because in HER2 positive early stage breast cancer, particularly that are hormone receptor positive, we are talking about extending maintenance treatment using neratinib, which has shown improvement in hormone receptor positive and those that didn't achieve PAT-CR. So I think biology really matters for risk stratification and choosing appropriate treatment options for our patients.
Absolutely. The follow-up from Extenet that showed the overall survival advantage, that's just, to me, such important data, because if you think about, for this group of women that's hormone receptor positive, node positive, that don't get a PAT-CR, also HER2 positive, of course, their risk of recurrence is so significant, even in the era of Catherine and particularly in the central nervous system. So to be able to show with 1 year of additional therapy, overall survival, I thought that was really, I was very excited about that.
Right. Carefully utilizing, diarrhea prophylaxis will help with the continuation of therapy with fewer interruptions and dose reductions and so on.
Absolutely.
So what's your practice for less than 2 centimeter ER positive, HER2 positive? in regards to adjuvant versus neoadjuvant approach?
So I tend to use more 1 centimeter as a cutoff, if that's greater than 1 centimeter and the patient's young, certainly. I so want the information to guide my adjuvant therapy, that I want to treat them neoadjuvantly just because I want to know, who will benefit, for example, from adjuvant TDM1 based on the Catherine data, who may benefit or get more of the benefit from the extended adjuvant therapy with neratinib. So I think for me, I find myself when I have a patient that goes to surgery first, struggling with those decisions, and I'm greedily, I want that data for myself. What is your practice?
So I have a personal problem between TCHP versus TH. So, such a big difference on toxicity. And patients on the APT trial have done so well under 2 centimeters, especially the ER positive, HER2 positive population. 7-year distant recurrence was like 1%. When I have a patient with clinically non-negative and less than 2 centimeters, I tend to recommend patient go straight for surgery and come back, and we talk about weekly paclitaxel and trastuzumab versus having, especially when you get to be a certain age where you're not going to potentially tolerate the TCHP regimen very well. As you know, TCH is fairly well tolerated. THP is very well tolerated, but when you do the TCHP, it's a whole different monster. So,
yeah, I agree too. I have also been sending patients for upfront surgery if they have small size tumors up to 2 centimeters and don't have many other bad prognostic features like a higher grade tumor or many other features. I do send them to upfront surgery and then give them Taxol with paclitaxel with trastuzumab based regimen, because APT trial has 9-year data with improvement in their progression-free survival and OS as well. But there definitely is a role for maintenance treatment in all of these HER2 positive patients, because no matter what we do, they tend to relapse much more as compared to other subsets of breast cancer patients. So I think something to keep in mind.
I think these are all great points. It's believe it or not, we're approaching our hour discussion. I've definitely learned a lot. And it's been great to discuss kind of the different practice patterns and the data with my colleagues here. So, I want to thank our attendees for tuning in. I definitely want to thank our sponsors, Pfizer, Seattle Genetics, and Puma. Information on how to obtain CME credits will follow shortly. But to our panelists and Bethany, thank you again. Any final thoughts?
No, this has all been just really great hearing you guys talk about all of the different considerations that you're making, as you're coming forward with these treatment decisions. It's just very encouraging. So thank you for letting me participate in this with you.
Thank you.
Thank you,
Awesome,
Bethany,
thank you.
for sharing your story. I think it makes all the big difference hearing from you personally, and makes it real what you went through and what are the real problems and what are your personal preferences, because that's what shared decision is all about these days in treatment decision making.
Thank you.